typo. So,
I'll be presenting on behalf of Medicine One. My topic is on aches and pains. A 67-year-old gentleman who is a known case of coronary artery disease presented with complaints of generalized weakness for 6 months with significant unintentional loss of weight and appetite. He was also found anemic in an outside hospital requiring transfusions. However, further evaluation was not done in an outside hospital. He has no fever or any night sweats. On coming here, his vitals were all stable with an ECOG of 2. He has pallor, and on examination, he has left axillary lymph node measuring 2 into 2 centimeters and right supraclavicular lymph node measuring 1 into 2 centimeters. Systemic examination was all within normal limits. On CNS examination, the power of upper limbs were 5 by 5, whereas lower limb is 4 by 5 bilaterally. But the reflexes are preserved 2 plus, plantars are flexures with no sensory deficit, and vibration sense is normal. Cervical tenderness elicit was present. Summarizing, a 67-year-old gentleman with history of generalized weakness, anemia, loss of weight, and loss of appetite. So because of his age and the presenting complaints, the first diagnosis differential we have considered was malignancy, which can be a hematological or solid organ tumor. We also consider other possibilities of autoimmune and infections because of a significant loss of weight and appetite and generalized weakness. And we have done an investigations which revealed bicytopenia with HB of 4.8 and WBC of 2200. And peripheral smear showed a dimorphic picture. Initially, LFT was normal except for the raised ALP of 2838. However, GGT was within normal limits. Calcium, phosphorus, LDH, uric acid, TSH are all within normal limits. In view of bicytopenia, we have done a bone marrow which shows necrosis with infiltration by a viable tumor, with suppression of the trilineage hematopoiesis, and bone tuberculosis shows osteosclerotic changes. So we have gone ahead and done an X-ray of the lumbosacral lesion, which shows multiple sclerotic lesions. You can see all the sclerotic patches. MRI spine was done, which shows a diffuse heterogeneity in the bone marrow signaling of the vertebral bodies, and degenerative changes are present in the C5, C6, and C6, C7 levels. So I would like to discuss a little bit more about the sclerotic bone lesions. However, rare we do come across multiple sclerotic lesions, and osteosclerosis means an abnormal increase in the bone density with hardening of the bone. There are multiple causes for sclerotic lesions, which can be classified as focal, multifocal, and diffuse. For today's topic, we will focus on the diffuse sclerotic lesion, bony lesions. There are multiple causes, but the major causes are metastasis, either from prostate in case of men and breast in case of women, Poem syndrome, lymphomas, leukemias, endocrinopathies like hyperthyroidism, renal osteodystrophy, myeloproliferative lesions like myelofibrosis, mastocytosis, and rarely certain drugs like hypervitamin D, fluoride levels, and sarcoidosis can also cause sclerotic bony lesions. Now, if you look at the metastasis in the X-ray, we can see that the sclerotic lesions caused by the metastatic lesions are usually ill-defined and diffuse. Here they show multiple sclerotic lesions over the spine, pelvic bone, and both the femurs. Whereas in case of multiple myeloma, which is the most common primary malignant neoplasm of the skeletal system, can also present with multiple sclerotic lesions, which is just proliferation of plasma cells. A variant of it, that is the Poem syndrome, usually presents with the polyneuropathy, organomegaly, endocrinopathy with elevated M protein and skin changes. The Poem syndrome also presents with multiple punctate osteoblastic lesions. Whereas in systemic mastocytosis, it is usually because of the proliferation of mast cells, which usually occurs in GI and in case of skin and also bone. So when it involves the bone, it can cause osteosclerotic lesions. So they usually present with GI symptoms like vomiting, loose stools, and urticaria. Coming to myelofibrosis, it is a chronic hematological disorder in which bone marrow is replaced by fibrosis. So they usually present with features of fatigue, fever, weight loss, night sweats, anemia, and hepatosplenomegaly. And the characteristic lesion is the jail bar appearance. Sarcoidosis, as we know, is a mostly incidental finding, but around 30 to 40% of the population can present with pulmonary symptoms. So in sarcoidosis also, they can see multiple osteoblastic lesions in the vertebral body. Sorry. Paget's disease, also known as osteitis deformis, it is a chronic condition which occurs because of the excessive bone breakdown. So this Paget's disease usually presents with multiple osteosclerotic lesions, multifocal osteosclerotic, but sometimes can present with diffuse sclerotic lesions. It has three stages, which is early lytic, mixed, and blastic. And during this blastic stage is when we can see an ivory vertebra. Even in cases of hyperparathyroidism and renal osteodystrophy, we can see osteosclerotic region, and the characteristic features is rugged jersey spine or salt pepper skull. And vitamin D, hypervitaminosis D, and fluorosis. Our patient had on distal rectal examination had a firm prostate, and ultrasound showed prostomagaly. We have done further workup which showed an elevated PSA of more than 1900. So we consider possibility of prostate malignancy. The immune profile on the bone marrow favors prostate primary. So we further imaging was done, which showed a possible metastasis to the liver and pleura also. So our patient has been diagnosed with prostatic cancer with metastasis. Prostate cancers are usually asymptomatic and can sometimes present with these symptoms or lower urinary tract symptoms. The most prognostic indicator is the metastasis to the bone, and the 5-year survival rate when metastasis to bone is less than 30%. And the diagnosis is usually made by PSA levels, or can be done by doing an MRI of prostate or biopsy of the prostate. Usually, the prognostic markers are visceral metastasis, high serum ALP, pain and presentation, low ECOG, and low HB. Our patient had all of the features. So bone metastasis is common in case of prostate cancers. And in case of earlier stage, around 10% of the people can present with bony metastasis. And in case of later stages, around 80% of the patients can have bony involvement. And treatment is usually, we give 4 to 6 weeks of androgen deprivation therapy. If it is not effective, then we can go ahead with chemotherapy and radiotherapy. So from this from this case, we can learn about how to approach different sclerotic lesions and how to classify them, and how does prostate cancer present with bone marrow infiltration. Thank you.
Thank you, Dr. Sharon. Any questions from the audience? Okay, we'll go on to the next case.